Welcome back to the HBO seminar this week. Thank you for joining us. I'm just gonna make a quick announcement before we jump into the presentations. Today we do have two presenters and they'll be splitting the time halfway through. And so we have Robert who will be presenting first and then we'll have Emily after that. But how we'll split it up is I'll let Robert present his talk. We'll go through all the questions for Robert and then we'll switch to Emily and do the same thing. So first off, we have Robert Chauvet here, who is a PhD student in biomedical engineering here at the University of Calgary. Robert first completed a BSc degree in mechanical engineering from the University of Alberta in 2021, following which he completed an MSc degree also in mechanical engineering at the University of Alberta in 2023. During his master's degree, he performed finite element modeling of head impacts for military helmet testing under the supervision of Dr. Chris Dennison and Dr. Lindsay Westover. He then started his PhD here in 2024 under the supervision of Dr. Corinne Roach at the McKay Institute, where he is studying the kinematics of ankle osteoarthritis in total ankle replacement surgeries. An interesting fact about Robert is that he spent his first year of engineering taking classes at the French campus in Edmonton, and that he was also a long-distance runner at U of A. Today, he will be presenting his research on talonavicular compensation for tibiotalar motion in total ankle replacement. Thank you, Robert.
Thank you for the introduction. Is this mic working? Is this good? Perfect. All right. So first off, ankle osteoarthritis can cause pain and stiffness in articulating joints. Typically in the ankle that affects the tibiotalar joint, so the joint between the tibia and the talus. That is the kind of when we talk about primary OA in the ankle, that is the joint we are talking about. Different from knee and hip osteoarthritis is that ankle OA typically comes post-traumatic. So an injury will happen, there'll be a slight change in bone or geometry or loading patterns, and then it'll develop arthritis later on in life. So you can see in this image, this is a osteoarthritic radiograph with the post-traumatic repairs shown there. And the kind of stat to back that up is that a 1 millimeter shift in the talus bone actually results in about a 46% change in the contact area of that joint. So a very small change to those bones result in very large changes to the contact mechanics, thus developing different wear patterns for OA. One of the kind of solutions for this is total ankle replacement. And when you get to an end stage of arthritis, you often undergo this surgery. It's becoming a more common option compared to previous surgeries such as a fusion surgery, which just isolates and fuses that joint together and doesn't allow any motion. So TAR replaces the tibia and talus articulating surfaces and allows some movement in that joint still along that flexion extension. And that is the motion we're going to be looking at today primarily, is that flexion extension. And that is the primary mechanism of that joint and of those two bones. So the kinematics of TAR is that ideally post-surgery, it maintains some movement. There is some clinical findings that it actually doesn't restore healthy kinematics, but more so only maintains the pre-surgical levels of motion. So it has those same patterns, we think, as the arthritic population prior to surgery. And then the question I guess we want to answer is how does that limited range of motion in that ankle post-surgery affect the surrounding joints? So does it have some sort of cascading effect to other joints? Are we going to see secondary OA? Are we going to see different kinematics in not only that tibiotalar joint, but also the subtalar, talonavicular, and LPA cuboid joints? So there has been some work done on the subtalar joint to quantify some of those compensatory motions. It doesn't see compensatory motion, especially in that flexion extension plane, which is the primary motion of that tibiotalar joint. The subtalar is primarily more an inversion conversion joint and doesn't really compensate for any of that flexion extension. There has been some studies looking at the talonavicular joint and its compensation in that flexion extension plane. These have been primarily two-dimensional radiograph studies where they haven't actually isolated the talonavicular joint, but more looked at the foot deformation and in that flexion extension plane. So more work is needed to really quantify that talonavicular compensation and whether it really acts as the mechanism for that talonavicular lack of motion. To study this, we're going to use dual fluoroscopy. Dual fluoroscopy can quantify individual joint kinematics using two orthogonal X-ray systems. So we get we can image dynamic functional movements of the body, and this provides errors of 1 millimeter and 1 degree for each bone that we want to track through those frames. The objective of the study is to explore the effects of total ankle replacement surgery on the adjacent joints in the surgical and as well as the contralateral limb. So for this study, we had a single participant, so we had a case study. This was a 65-year-old female who was about 2.2 years post-TAR surgery. Her mobility scores through some surveys indicated a full recovery. So pain and mobility wise, she would be considered a healthy, active individual. There was no signs of secondary OA in any of their surrounding joints, although this was only 2.2 years after surgery, and those can take a while to develop if there was going to be secondary OA. And then there's also no signs of OA in the contralateral limb. So for all intents and purposes, that looked like a healthy limb on radiographs. We performed an overground barefoot walking trial captured at 120 hertz. And then we also had some controls come in. So we had 5 participants as controls, aged about 32 years. So DF processing pipeline kind of has 2 prongs to it. First, we do a DF data collection where we capture overground walking. So we can see here the 2 X-rays and the bones as in the field of view there. Then we also collect simultaneously a CT data where we get slices and we can segment out the 3-dimensional bone models. And for the study, we segmented out the tibia, talus, calcaneus, cuboid, and talonavicular. So all the bones necessary to calculate all the joints that we want to talk about. And then we do something called model-based tracking. It's basically a 2D to 3D registration process. So we have those 2 two-dimensional radiographs. We can match up the 3-dimensional bones in both frames. And then the space that they occupy together in terms of the room and the calibration, we can actually get 3D position of that bone. And from that, we can do that for every single frame, get motion of those joints. We then go through the process of applying anatomical coordinate systems, to be able to derive kinematics for joint angles and all of that. So we take our bone kinematics, apply those coordinate systems, and then take relative to each other, we need to get our joint kinematics. So if we jump right into some of the results for this study, we can see here, this is the surgical and contralateral limb. So you can see on the surgical limb that there's a big space there in between the tibia and talus, and that's where the implant is. And just, there's an extra thick cartilage simulant layer they put in there. But what I want you to notice mostly in these 2 images is that the tibia moves a lot more across the talus in the contralateral limb than it does in the surgical limb. The surgical limb, it looks quite stiff and has a limited range of motion there. And we'll jump into some of the other results to kind of show more what that is. So if we look at the tibiotalar graph on this side, you can see the controls are in gray. And the contralateral side, so the red line there, actually follows the controls fairly well in terms of pattern and range of motion values. And we can see the operative side definitely has a limited range of motion in both dorsal and plantar flexion across that sand space. And if we go over to the other side and we look at the talonavicular joint, Again, the controls are in the gray. We can see that the operative side has a much larger range of motion across that stance phase than the contralateral side. Blue has a much larger range of motion than the red line. And if we look at those values, it's just taking the range of motion, so taking the maximum and minimum of those curves. We can see that in the talonavicular and tibiotalar, the results are quite different than the controls. So in the talonavicular, we get very high range of motion compared to both contralateral controls. And then in the tibiotalar, we're also seeing reduced range of motion in the operative limb compared to the contralateral and controls as well. So kind of the key takeaways of this study is that the tibiotalar range of motion is reduced in the post-surgical limb compared to both the healthy controls and the contralateral side. And then the talonavicular range of motion is increased in the post-surgical limb compared to both the contralateral and the healthy controls again. And this kind of is driving some research questions moving forward for us, that the talonavicular joint looks promising to explore this compensatory motion phenomenon post-TAR surgery. And then lastly, that we need DF to capture some of this information instead of marker motion capture. It is very hard to palpate for these small joints and bones inside of the foot to capture each individual joint that we want to look at. So we need to really use DF to capture all of this information. So future work, we need a larger study to draw conclusions. We only have a case study. This is more of a pilot to then kind of kickstart a longer longitudinal analysis of pre-surgical patients, comparing them to the post-surgery patients. So we can really isolate the effects of that surgical intervention and see what that surgery is doing to their kinematics in the hind and mid foot. Then lastly, we would like to also age and sex match some controls for a better representation of healthy kinematics. So it depends what we consider healthy, but we can have a younger, more active population, around 20 years old, consider healthy, or we can age match a older population, because a lot of OA people are older, around 60 to 65 years old. And then we can compare those kinematics as healthy as at that old age. So we can kind of look at both sides of those ages. Thank you for listening. I'd be happy to take any questions you have.
Start off with questions for Robert.
Nice presentation, Robert. I was wondering, you talked about how small changes in the ankle position, bone position, can cause dramatic changes in contact area. And we had Justin a few weeks ago come in and give us sort of a presentation on that in the wrist. So like, what would it take? What data do you need in your model in order to go and calculate the contact areas between in some of these joints? And do you think that's
Yeah, we can definitely already do that. It just wasn't, we didn't really see much interesting in this for now. Again, this is more of the pilot side of things. When we actually go to do our larger cohort groups and the longitudinal side of things, we actually want to move some of that work over to like an SSM pipeline, where we can actually compare across the population using the similar like correspondence model landmarks. And the way we're doing it in the lab right now, comparing across participants is very hard. It's doing statistically basically. So that is kind of future work, and I'm going to be working on that a lot this fall. I'm going down to Utah to learn their pipelines for that. So
Andrew and then Benno.
So do you guys collect horse data at all?
we do. We have an instrumented treadmill that they walk across. We currently only use it for looking at the heel strike and toe off frames, just so we know where those occur. But
No one's looked in to see like how these alternative knives are affecting what the joint loading.
no, not yet. That is, you can ask Emily about that maybe. That's maybe future work for her. But yes, now there's not especially when we're looking at individual joints and stuff, a lot of the software like OpenSim, if you wanted to look at joint mechanics are not specific enough for all those bones, right? It's a lot of gross motion things. So yeah, we wish there was a model to look at individual joints like that within personality.
Ben, you had a question?
I don't know if you know, but about 30 years ago, we were here in the lab on an ankle prosthesis. And it is on the market,
Okay,
but the difference to then the one that you have is that it's 3 pieces. So it has something like for the tibia and something like for the calcaneus, and then a floating piece in between. And the first question I have is, how would we expect with respect to your results? How would they be different for a 3-piece procedure?
yeah, so that 3-piece one, I'm assuming would replace that talus with another component as well. So you're completely removing the talus.
Kind of mimicking the tail.
I would say it probably has, I think the best kinematics and best results post-surgery to get the closest to like healthy kinematics in the ankle would probably be only the 2-piece, because you're allowing that talus to remain intact with the calcaneus, like those, if there's no OA there doesn't seem a reason to replace all 3 bones. And then obviously some surgeries, you need to replace all 3. There's arthritis in all joints, right? But if we're just looking at the comparison between the 2 and the 3, I'd say it would be tough to replicate true healthy movement with the 3-piece prosthetic
With
insert,
3-piece.
with the 3-piece.
Would it be easier?
It'd be harder. Just because you're designing for 2 separate movements in that hind foot. You're designing for that flexion extension, and then you're also trying to design for that inversion eversion of that subtalar joint. And yeah, I don't see how it would be easier.
Don't remember exactly the results after the fact, but I seem to remember that the results were better for the 3-piece than for the 2-piece.
In terms of comparing back to healthy kinematics. And was that with motion capture data then? So you're looking at like gross movement of the ankle instead of just the individual joints?
We had some bone pins in it.
Oh, cool, okay, yeah,
I mean, it's cadaver study.
right. Right. Yeah, my assumption would be that it's worse, but if there's papers to prove me wrong, then that's good data. And I'll look into that. I haven't seen that.
Is currently the 2-piece replacement is the one that is used?
Yeah.
Nobody uses 3.
I've never heard of a 3-piece one before.
That's right.
Sorry, that one's not a 3-piece? It's
No,
not 2
well, he's
and
talking
then
about
the
replacing
insert?
the calcaneus as well.
I think you guys are talking about 2 different things. You're talking about a whole fusion of the,
No, replacement of the whole hind foot.
yes, and you're talking about just the tibiotalar joint, correct?
Oh. Okay,
I think it's a miscommunication.
gotcha.
Yeah, so you're talking about like a fusion of the subtalar joint
Yeah.
along with a
Yeah.
replacement of the tibiotalar joint.
Yeah.
You're talking about 2-piece versus 3-piece tibiotalar replacement,
Oh.
which
okay.
yours is a 3-piece,
Yeah,
right?
ours is the 3-piece then. If you consider that cartilage layer in between, it does have a little insert there to mimic some cartilage. Yeah.
And is that similar to the design you've worked on as well, that was 3-piece?
Sorry.
Is that similar to what you worked on? Your 3 pieces are the tibia implant, the talus implant, and then the polyethylene implant?
Right.
Yeah.
Okay, yeah.
So yeah, it should be the same.
That's what we do as
Is
well.
what you have.
Yeah.
Maybe that revises your.
Yeah, I wasn't sure how it piece the whole hind foot would have worked, but yeah, they do put a little spacer in between the joints to mimic a little bit of cartilage. And you could actually see it on those videos there. It was quite a
The
large.
3rd piece was quite substantial.
Go back to your photo.
So you can see the spacing, like there is like we don't segment that third.
And that is through floating,
There is a piece there. There is,
is it floating or is it fixed?
it is floating.
And held together by the ligaments?
That's a great question. They do almost like a partial dissection of that to insert everything, so. Um,
Anyone have any other questions for Robert? I will ask. So with the case study, with the one participant, you did find that talonavicular compensation is a promising way to go forward, but do you think as you add more participants and test that, do you think there could be other compensation patterns that kind of evolve that you might have to take into account?
Yeah, we might see results in some of the other joints as well. It's just, again, we kind of think about it as like that primary movement of the tibiotalar joint is that flexion extension. So we're looking for another joint that can also move in that flexion extension plane, and the talonavicular makes sense for that. And so we see the results. So we kind of expect there to be some compensation in that joint. But there could be other ones as well.
And then in your PhD study, so you're looking at longitudinally testing that. So what does that look like in terms of like how long will you follow participants for, and do you have that idea yet?
We've brought in most of our cohort for the pre-surgical side of things already, so they come in as soon as they have surgery scheduled, basically, so it can be anywhere from about a month or a couple weeks to a couple months before they go in for surgery, and then we'll wait a year post-surgery, and that's when they're considered full recovery, like they're fully there for a long time after that, and then we enter them again, same protocol, same everything, and just looking at the backs.
Okay, so if there are no other questions, did you have one? Yeah.
It's just possible suggestion. Get over around walking, work like it is, they want, they try to go money for this, or they just walk, just one. So you might wanna look at a pressure sensor too, on top of the.
There you
You already have, alright, yeah, just-
Emily should have done it. Yeah, because you have to know how the forces are distributed between the high foot.
I think that's where we're dealing. with the process of this going on.
Yeah, pulling some sort of DA model or something between joints would be kind of the next step. in this work.
And a couple of people have done it like multi-segment foot model with skin markers, but it's still like 3 segments versus like, I don't know, 10 of them, we have to 12 bones to account for, so. Bit of a, like, too many unknowns on an equation situation.
Okay, perfect. I think that nicely leads into Emily's talk, so thank you, Robert, for that. All right, so our next speaker for today is Emily Smith, who is a PhD student in biomedical engineering as well here at the University of Calgary. Emily holds a BSc honors degree in biomechanics, which she completed here at UCalgary from 2017 to 2022. And during this program, she first got involved with research here at the HPL with Dr. Darren Stefanition and Dr. Bill Wana, performing biomechanical evaluations of athletic equipment. She then went on to do an MSc degree in biomedical engineering, also here at UCalgary from 2022 to 2024, under the supervision of Dr. Stephen Boyd and Dr. Lauren Burt. And her thesis was focused on using medical imaging for evaluation of bone health in elite athletes. Since 2024, she's been working here at the McCaig Institute using medical imaging and computational modeling to evaluate osteoarthritis as part of her PhD under the supervision of Dr. Florent Roche. And when I asked her about an interesting fact about herself, she said that she's played 5 seasons with the Dinos women's field hockey team, which is pretty exciting. And I just want to add an interesting fact about Emily and Robert, that they are both students who reached out to me and actually made the effort of making me switch speakers so they could present at the HPL seminar, which is very unlikely to happen. Usually I'm the one chasing after people to present. So be like Emily and Robert. So the title of Emily's talk will be Prescribed Ankle Foot Orthoses, Alter Tibiotalar Joint Angles in Adults with Cerebral Palsy During Walking. Thank you.
Thanks, Asha.
So a couple of premises. First of all, I want to say sorry if we just set the stage for something that I'm not going to speak about. Everything that we just spoke about is stuff that's going to be included in my PhD work, but this is a side project that I've kind of taken on before I decided that. So if you have questions about all that other stuff, I'll come back at some point, but I can't answer them at this point. Secondly, obviously Robert and I are lab mates and have a lot of the same information. So this is going to be a bit of a repeat, but he set the stage for the methods and everything. So hopefully you're all DNF experts by the end of this, but sorry in advance for some repetition. So first, I'd like to introduce you to my population. We're working with individuals with cerebral palsy. And cerebral palsy, or CP, is a condition that is a neurodevelopmental condition impacting motor control and movement. And it is often associated with an array of foot deformities, prevalent in up to 93% of individuals with CP. And some of the most common foot deformities are seen in this graphic on the right here. We see that they're kind of divided into a hindfoot, midfoot, and inversion, eversion categories. So some of the most common foot deformities that we see in this population that we were working with were equinus, which we can see in that top corner. That's where we're in plantar flexion, and plantar valgus, where we have a combination of planus and valgus. Now, foot deformities often lead to a set of improper loading mechanics, which, if we have foot deformities, often leads to improper loading of that foot and ankle joint. Now, the foot and ankle, as we've already discussed, is made up of a couple of different bones here. In the hindfoot and the midfoot, we have 5 bones in particular that set us up for 4 joints. The ones that I'm going to be focusing on specifically are the tibia, the talus, and the joint in between them, which is the tibiotalar joint. Now, the tibiotalar joint's primary motion is in that sagittal plane, so as we're walking, and that is plantar and dorsiflexion. Plantar flexion is when we're pointing our toes, so we have a negative angle, and our dorsiflexion is pointing up. Now, individuals with cerebral palsy are also at a high risk of osteoarthritis, where osteoarthritis, or OA, is a degenerative joint disease that impacts the bones and surrounding cartilage of the joint. Now, we don't know for sure, but what we're thinking is that these individuals are at a higher risk of earlier onset arthritis because of their foot deformities, or in part because of their foot deformities, which then lead to an altered gait, altered loading, which could then lead to osteoarthritis. Now, this has been seen in typically developed individuals, but has been studied a lot less in people with CP, so we're not quite sure how correlation is there. So this begs the question of, if we know that they have improper biomechanics, how can we act to mitigate or correct some of these at the foot and ankle specifically? And for this, we can use ankle foot orthoses, or AFOs. And an AFO, as we see on the right here, is an external brace that is worn inside of the shoe. We have an example of a hinged AFO in that purpley gray color here, and a semi-rigid AFO in the black. And they have different purposes depending on the individual's prescription. So these braces are individualized and prescribed based on need. They have a different, or there are a couple different types of prescription, and this is done from an orthotist based on evaluation and diagnosis of the individual and their mechanics and their condition. Now, the purpose of an AFO depends again on that individual, but some of the ones that I'd like to highlight are that they help to facilitate movement and they alter the targeted range of motion. So there are some limitations with these prescriptions, first of which being that there tends to be a lack of consensus in the individuals who might benefit from AFOs. And it's not just that if an individual has equinus foot deformity, they're automatically prescribed this AFO. So there's a lot of things that go into that, and there doesn't seem to be a standardization on who is getting these AFOs. And with that, up to 58% of AFO prescriptions might actually be inappropriate or inadequate, whether that's because something's got overlooked in the prescription or just we don't truly have an understanding of the kinematics, we're not sure. But the AFO studies that we do have tend to show that there are improvements in gross movement when we're using these AFOs, but this is often measured with skin marker motion capture. And while skin marker motion capture isn't inherently bad, it does give us some indication of how these individuals are moving. This works at kind of a larger scale, and there are a lot of assumptions that need to be taken with this. So as we can see in this photo, when we are using skin marker motion capture, we have to use those little retroreflective markers, and we're palpating for those anatomical landmarks, which I don't know if you've ever tried to palpate a foot and feel specific landmarks, but it's pretty challenging to figure out which one is which. And so that leads us to some inaccuracies, especially if we're trying to differentiate between tibiotalar joint and subtalar joint and all these tiny little joints in between. To be able to accurately say, yes, I have identified these points is pretty challenging. We also come across that soft tissue artifact, and when we are creating these segments, we're considering the foot as a rigid segment, which doesn't allow for us to look at those individual joint differentiations. So to overcome this limitation, we use a motion analysis technology that utilizes medical imaging. And this is called dual fluoroscopy, or DF. And DF is a set of two orthogonal dynamic X-rays, high-speed X-rays that give us somewhat of an X-ray video. And as we can see here, those X-rays come out of the emitters and they're captured on the intensifiers on the other side. Within that field of view, we can capture those X-ray videos. And we use this in combination with computer tomography to get us that 2D, 3D registration of the bone. And some of the advantages that we have with DF over traditional motion capture is that we get sub-degree and sub-millimeter accuracy in 3D. And we also have that ability to capture individual bones in joint motion. So the objective of my study then was to look at how AFOs impact the tibiotalar joint kinematics in adults with cerebral palsy. And we're looking specifically at that AFO condition compared to our barefoot and shod walking in these individuals. Now, I have a group of individuals in this study. We have 5 people that we're considering a case series. So we have 3 individuals that have talonavicular foot deformity, which again, that is a flat midfoot versus an arch. Fallen midfoot, and then valgus is an eversion. Equinus is when we have that overly plantarflex foot, and then equinoplanovalgus is actually a combination of the two. So I'm going to be treating each of these as a unique case, and we'll go through the results one by one and kind of discuss them as a group at the end. So each of these individuals participated in this study walking barefoot, shod, and shod using their AFO. So if anybody's not heard shod before, shod just means while wearing a shoe. And the AFO itself has to be inserted within the shoe. So we can't specifically isolate for the AFO, but the AFO is formed in the shoe. But when I'm speaking about the AFO trial, this is what we're using. Now, we've already gone through the DF processing pipeline, so I'm going to work through this a little bit faster. But we have those 2 parallel paths. The first is we require that CT, the computer tomography scan. We get an image stack that we can segment and then produce our 3D bone models. At the same time, we're doing the dual fluoroscopy data collection, for which we get these video radiographs, and then we take those 2 together and complete our model-based tracking. Now, the dual fluoroscopy data collection is an overground walking. We don't actually use that treadmill, as we mentioned, and we have those X-rays that shoot out from the emitters, and we capture them within that field of view. So we can see as this person walks across the treadmill, they heel strike at the outside of that orange box, and then we get all of stand space onto toe off, and that is our field of view. The CT scan produces these 3D bone models by our segmentation, and this is what we're using in the next step with the model-based tracking. So model-based tracking, again, sorry, I've stolen some visuals from somebody else, but these radiographs are our 2-dimensional images. And then we're able to bring in these 3-dimensional bone models. And then based on this manual model-based tracking, we're able to see how these bones move in space. So this is just kind of a visualization of what that 2D, 3D registration actually outputs. And then from there, we're able to assign anatomical coordinate systems to our bones of interest. For this, because we're looking at the tibiotalar joint, we assign coordinates to the tibia and the talus. And then we can calculate the joint angles in dorsine and plantar flexion for that tibiotalar joint as seen on the right there. And just another note, I've already mentioned this, but we're only looking at stand space. So that's only the portion of the gait cycle for which that foot is fully on the ground. So heel strike through the mid stance into toe off. So before we get into this, I'll just break down kind of the display of my results. My first participant is a little bit unique compared to the other 4 because they actually had 2 AFOs. So they don't have a barefoot trial, but we do have a hinged AFO, a rigid AFO, and a shod AFO. So what we've got here is each of those joint kinematics overlaid compared to a control in the dotted black, that's the control mean, and the control standard deviation is that gray bar there. So for this first individual, their foot deformity was planovalgus, and they were prescribed an AFO that was a semi-rigid dermoplastic as seen in that blue box there. So we're looking at the light blue, joint angle as we're going across here. The purpose of this AFO was to prevent plantar flexion in swing and then prevent excessive dorsiflexion in stance fade. Now, as I mentioned, we're not looking at swing because that's outside of our field of view, so I can't necessarily speak to that. And that will be a common theme throughout a lot of these, when that is the main goal of that AFO is to prevent something happening in swing. But what we can say is, although excessive dorsiflexion may be more of a subjective term, we're seeing that light blue AFO compared to the SHOD trial is actually lower, closer to that neutral, which means that it is preventing dorsiflexion to some extent. Next, this is the same individual, just with a different AFO, which is really cool to see how different AFOs can actually impact these joint kinematics in the same person. The same foot deformity, but this is with a hinged thermoplastic AFO. And again, purpose of this was to prevent plantar flexion in swing, but wow, we're going too fast. But with this, we can see that it actually did the opposite in stance, where it brought them into more of a dorsiflex position compared to both their SHOD and their rigid AFO trial, which is interesting because that's the opposite of what it's trying to prevent in swing. Next, moving on to a new individual with the same foot deformity without plano valgus. Their AFO was a custom hinged AFO with what is called a supramalleolar orthosis or SMO insert. And we can just see that's the kind of like bulky thing in the middle of that buckle there. And now for this individual and the ones following, we do have a barefoot condition. So that's that red graph around there, or sorry, the red line on the graph, and then the green SHOD, which stays AFO throughout. So the purpose, again, of this was to prevent plantar flexion in swing. But what I will comment on is that we are seeing that the AFO compared to the SHOD conditions is actually less plantar flexed or more dorsiflexed, I should say. And it does seem to change the timing of the movement in the AFO condition compared to both the SHOD and the barefoot conditions. Next, this is our last individual that had a plano valgus foot deformity, and this was a semi-rigid carbon fiber AFO with an anterior shell. So what we're seeing here, or sorry, pardon me, the purpose of this AFO was to prevent plantar flexion in swing and to limit dorsiflexion. And I'm really going to focus on this dorsiflexion component because what we're seeing is, especially compared to the last couple of individuals that we looked at, we have a really, really high starting point for that dorsiflexion. So we're really high in dorsiflexion, and by using that AFO, we're actually bringing them down from the barefoot and the SHOD being up in the 20s range of motion, 20-degree range of motion, we're bringing them all the way closer down to that neutral area, way closer to our typically developed control line, which is quite interesting. So we would say, yes, it did limit dorsiflexion. Now, this is a new foot deformity. This is somebody who had an equinus contracture, and remember that equinus is when the toes are overly pointed, so they're in plantar flexion, and that's why they're mostly in that negative area here. Their AFO was an accommodative custom thermoplastic articulated AFO, and what that accommodative means is essentially this AFO is set at a certain range of motion at the bottom, and they can dorsiflex, but they aren't allowed to plantarflex past that set limit. So the purpose of this then was to prevent excessive plantar flexion in both swing and stance. And if we look at that blue line compared to both the SHOD and the, especially compared to the SHOD condition, we can see that there was overall generally less plantar flexion, bringing it up closer to the neutral. And then in the toe off region, a little bit like kind of around 80% of stance there, we see that they're actually going into dorsiflexion for the first time compared to that barefoot and SHOD trial. So it looks like it might give them a little bit more dorsiflexion using this. And this is our last individual. They had the equinoplano valgus, which is a combination of both of those deformities. And what we're seeing here is they have a custom thermoplastic semi-rigid AFO. Its purpose primarily here was to prevent excessive dorsiflexion in stance phase. Now, again, excessive may be a little bit of a subjective term, but when we're looking at it in terms of their own trials, what we're seeing is that this AFO, this AFO brings that dorsiflexion down again more towards the typically developed controls compared to the barefoot, and is actually following along that trend line pretty nicely. Now, this is the result from all of our participants all put together on one graph, which kind of seems like a whole lot of nothing at first glance. But what I want to focus in on is that if we take away the barefoot and the SHOD, and we just, oh, I'm sorry, You can't particularly see it, but there is a standard deviation behind there as well. The black is the control means, and if we're looking at all of these individuals together in the AFO condition, that is bringing them pretty close to that trend of following along the typically developed controls, especially compared to what we're seeing with the parapet and shot. So we're bringing it the highly dorsiflexed individuals a little bit more plantarflex. We're bringing the highly plantarflexed individuals a little bit more dorsiflexed. And this dotted line here in the blue is just showing because CP1 had 2 AFOs, so that's one of their AFOs, and the other is the solid blue line. So in conclusion, what we do see is perhaps proper AFO prescription may bring these individuals more close to, bring their joints angles closer to that of typically developed controls. And we can see that we do have the ability to manipulate these joint angles by prescribing AFOs. And because this was a feasibility study, we were also able to see that we are able to successfully measure differences in ankle joint motion using dual fluoroscopy. Now, there were a couple discussion points and limitations that I'd like to point out with this study in particular, and that is that AFO prescription. We looked at it in isolation in terms of sagittal plane motion for the tibiotalar joint, which is probably not how orthotists are approaching it. A lot of these AFO prescriptions are a little bit more holistic. There might be more focus on pain management or postural control, which is something that we didn't consider much in these specific results. Also, CP is a very multifaceted condition. There's a lot of neurological component. It's a neurological condition, and we are only looking at kinematics here. So there may be components of muscle spasticity or different postural and gait effects that we didn't necessarily take into account here that might have a little bit more of an impact on the results than what we're showing. And in that same idea, these prescriptions for AFOs are often based on a full gait assessment and have been shown to help gross movement, but we're not actually sure what it's doing at that angle, at that joint angle, which is what this work is trying to do. There's also very, very limited research in adults with cerebral palsy. So this is a childhood onset condition where you pass at birth, and a lot of the studies are looking at that growth and development period. And then it seems when they turn 18, a lot of it just kind of drops off. So these individuals are left with not a lot of information on how their condition might progress. And it is considered a non-progressive condition, though osteoarthritis itself is a progressive condition. So if they're at risk of that, they should be able to know what to expect. Also, this is more just us. In speaking with participants, we found that AFO disuse is pretty high in this group. And we're not sure if that is prescription-based or if it was more based on social factors. But the fact that there is no consistent prescription, I shouldn't say no, but limited consistency and no standard in prescription is a problem. And we need to make sure that any research that we do can help inform how AFOs are either made or prescribed. Some future work within this study would be great if we could look at those other joints to get a full foot profile. We only looked at the tibiotalar joint, but to get a full hind foot, we would need the subtalar, and then looking into the midfoot would also include the talonavicular and calcaneal cuboid joints. It would also be awesome if we could get enough people in this study to include a group analysis, either that be by foot deformity or by AFO type or by AFO purpose, to do some kind of statistical analysis between those groups. Further, we would love to do other kinds of motion and see how that AFO is influencing the inversion, eversion, or internal external rotation of that bone motion. And that's all I've got today. Thanks so much for listening, and I'd be happy to take any questions now.
There's a lot of different spots I've had in here over the years. They focus on healthy controls, but an argument I'd say against that is your joints get used to a certain range of motion, and that is your. So by altering their kinematics that late in life, are you actually going to have an effect on the way or actually speed up the progression? Because you're now altering what that joint got used to doing to give it a whole new mechanical profile.
I agree with you, and I guess I should preface that these individuals have worn AFOs their whole life. So they're prescribed the AFOs at a very young age, and they have been wearing them essentially since they could walk independently, and they continue to wear them. So it's not that they're coming in at 18 years old or 25 years old, or we're saying, oh, you have cerebral palsy and this foot deformity, now wear this AFO and see how it corrects it. I agree with you that I think that that would be detrimental.
Would another line of focus be kids, like I know it's really looked at, but if you're trying to correct emotion, would it be better to start younger when?
It would be, I don't think ethics is big on radiating children, but if we could get to that point, that would absolutely be great. And I think it would be awesome also to do a longitudinal study to see, bring them in when they're younger, see how their bones develop and see how their kinematics develop over that time. In a perfect world, that would be a great study.
But would you know how to change it?
I'm sorry,
Would you know how to change it? The movement?
how to change the movement? I guess that would be more of something that you would want to work with a multidisciplinary team. Like we would be the ones that gather the results and say, this is what's happening, and then perhaps we give that to their physiotherapist or some type
But
of,
at the moment, you don't know it.
I'm sorry, I don't understand.
At the moment, you don't.
At
know.
the moment, we don't.
You know, you have 5 subjects, 5 different. And they have different results, so you don't know whether the difference is because they have similar problems but solve it differently, or they have different problems and solve it accordingly.
Right, so that's a great point, is that we don't actually know what's going on. And what we were thinking before we analyzed these results is that we have 3 people with the same foot deformity, so we would assume that they would have similar joint angles, but what actually happened is that they didn't. And that is enough for us to say there might be more things going on. So I think that there needs to be a lot more people in this study for us to say that we know what's going on and for us to see trends among them, but right now we don't know. We don't know what to expect for foot deformity, we don't know what to expect for the AFO, we don't know what to expect for that combination between them either.
So with ones that have the same foot deformity, do they have a similar cerebral palsy?
Yeah, that's a good question. So cerebral palsy is evaluated, I guess, on a scale. It's called the GMSCS scale. And that is based on the severity of their neurocognitive abilities, right? So I actually might have it in my slides. I don't know how to get it. I'll just speculate. So of those 3 people that had the same foot deformity, we only included people that were GMSCS level 1 and 2, because, that's perfect, thank you. No, it's not in there, but we, thanks anyway. We did have, 2 people that were GMSCS level 1, so that is like the, I guess, more mild condition, and then GMSCS level 2 is where they need some type of aid to navigate upstairs at least, so that would be a balance, a posture, and so, no, there was a difference between those, and that could definitely lead to a difference in these biomechanics. And one thing that we just noticed, kind of not actually in terms of these results, but just as some of these individuals were coming through, there was a big difference in cognition and just ability to understand what we were asking them to do. There was also a big difference in spasticity, and we had some people that had ataxia, so they have differences in coordination of movement. So there's so many things that go into this that can influence the way that they're walking. And of course, when we're looking at normalized graphs, that might make it seem like they're more similar, but if we were to look at these in terms of the entire trial, we would see that it actually took person A 5 seconds to go through the trial, and it took person B 37 seconds to go through the trial. So we can't even necessarily say that even though their joint kinematics are the same, their loading rate is different, and the way that they're moving all through that trial might be completely different. So there's a lot of work still to be done in this.
Kind of going off that question, on your graphs where you have the 3 for your shot, barefoot, and then your AFOs. The one thing I noticed was the yellow line, whoever that participant is, had the biggest change going from like the barefoot and shot to the AFO. And as you mentioned, like they were all quite different in their cerebral palsy and not the deformity itself. Was there anything that you can remember off the top of your head about that person?
Absolutely can. So this person had what we would call crouch gait. And if anybody's not familiar with crouch gait, it essentially means that they have excessive flexion at the hips and at the knees, which then puts them into excessive flexion at the ankles. So if their ankle is normally like this, when they're going through barefoot and shod, and then we put them into a rigid AFO that brings their ankle to this, that's gonna bring them from an excessive dorsiflexion to a more plantar flexion, which brings them closer to neutral. So that is one example, and a really good example of how we can't necessarily eliminate those things and still think that we're looking at the person, and looking at the kinematics and being able to extract all of the relevant details, because there's a lot that goes on behind the scenes, I guess, of these kinematics that would influence the way that we're seeing those joints.
Because when you said that, when we look at the AFO, they're all quite squished together. To me, the difference almost stems mostly from that yellow participant. And so I'm wondering then, my follow-up question is, are some of these participants like, on that spectrum of how, much their deformity affects their day-to-day life or how bad their cerebral palsy is? Like, do you think there are people in here that are using AFOs but don't actually benefit from it?
There are a couple people in here that have their AFOs, have been forced to wear them until they were 18, and then the day that they turned 18, they stopped wearing them. And that was because, again, just in speaking to the participants, I guess, anecdotally, it was more, they were like, I don't think it helped. It was painful. It was annoying. It was just clunky and cumbersome. And so for them, they don't have the perception that it's actually helping. And so I think that that could also be an influence in whether or not they wear it. And then if they discontinue to wear it for 5 years, and then we're imaging them at 23 years old, they might have had some like not disuse, but like disfamiliarity with it that might negatively impact the way that they're wearing it too. So.
Sorry, last question about that, then following up. Do you think from your study there could be an outcome? I know you said like you would want to hopefully show them results that encourage them to wear these, but could it go the other way where you show people that, okay, maybe for these group of people, you don't actually need it?
Yeah, I think it could easily go either way, and I think that both results are very valuable because these are very expensive pieces of equipment, and if we are just prescribing them based on, oh, this person has cerebral palsy, so they probably should wear an AFO, and then they have to pay, I don't know if it's out of pocket, but perhaps they have to pay out of pocket $3,000, and then they're growing and they're having to get a new AFO each time they grow. I think that if we show that that is not actually helping them, it might be better to just go forward with some other type of method of either physiotherapy or balance control or something like that.
Adam and then.
Two questions.
Yeah.
First one, nice presentation. I was wondering if you were able to make any judgments on like, rigid versus semi-rigid orthosis and which was better. Like I know people generally have one or the other and you have a variety of conditions, variety of levels of cerebral palsy, but, from what you saw, make that judgment, or one day if you expand the data set, do you think that judgment is possible?
That's a great question. Frankly, I don't know really what the difference between a semi-rigid and rigid AFO is. If I were to, in an ideal world, if we could classify this as hinged or rigid, that would be awesome, or category B in between. I think that the more classifications we have, the more complex it makes to make different, or make observe differences between them, but in terms of the semi-rigid and the rigid AFO, I'm not sure that I would be able to say there was much difference other than, yeah, compared to the hinge, I'm sure there would be differences in that angle, but the semi-rigid was just a little bit more compliant, but even just in holding it, you really couldn't tell much of a difference between them.
For some reason I thought there were more binary like differences than that, but it doesn't sound like, it sounds like every device is different.
Yeah, very
Okay.
much.
That makes sense. And then next question is, feels like this is probably infeasible for like a prescription for this, like for this process to be worked into the prescription process for, assigning somebody an AFO. So how do you envision like the results of this informing what, an orthotist like, prescribes somebody?
Yeah, it would be great if we could get a DF lab set up, like a gait lab in every kind of orthotics place, but my vision for this would be more you're right, in the same way to binarize or to categorize these AFOs and say, generally, people with this foot deformity benefit from this AFO because of this. And so being able to kind of make like even some type of decision tree of like, if you have this, go this way or that way. And I think it would be great. And although it is great to look at kinematics and science and say, look, this is exactly what it's doing. The way that the participant patient feels about it is more what's going to influence whether they wear it or not on the time. So to have perhaps a couple options, say, hey, take these home, see which one feels better. Based on that, we're gonna do a customization. That would be the way that I would like the study to go, to kind of get a better understanding, generally, the science of each of these, how it's impacting the joints, and then allowing input, individualization and customization.
Corinne, you had a question and then we'll go to Ben.
Well, you brought up a really good point, with the differences, like the yellow line, right? Like so much dorsiflexion, and we think that's because they have a crouch gait. But I'm wondering if you want to chat about the neutral position problem we ran into, and like, I would love this group's like thoughts on it, because I don't know like what the rate is.
Yeah, that's a great question. So, I guess I'll just explain, when we are going through and calculating joint angles, in order to calculate the joint angle, we need to have a neutral position to compare it to. In cross data, we have them come in to a neutral position where they're standing, we ask them to lift a leg and stand in a neutral position. For mine, when we ask them to do that, people with postural and balance control have a really hard time lifting a leg, and a lot of them have a hard time holding onto things and lifting a leg. So it's been a challenge to do that. So instead of doing that, what we're doing is we are taking the most neutral position of their stance. So as they're coming through, when their foot is fully on the ground and they're at their most 90-degree position, that's our imposed neutral. Because what we were finding is when they're coming in and they're doing that, the neutral position that we're asking them to, they're either really plantar flexing coming back like this, or they're really dorsiflexing coming forward like this. And that was because they had a hard time finding that neutral position. So we're not sure if our imposed neutral is actually imposing true results or not. I would love to hear feedback, thoughts. Any ideas on how to approach this problem?
Like post analysis, because like in a perfect world, we'd like design a jig, right? And like put them into that 90 degrees so that we can see clearly like when somebody has crouch gait or not. But we kind of realized this like halfway through data collection.
Feasibility pilot study.
Yep.
We're figuring it out as we go.
While people think of some suggestions for them, I'll let Ben ask his question.
Could you go to the diagram dorsiflexion as a function of time, that the first one that you showed?
So sorry, I thought I had it. I can't get it. So, see all the slides. Thanks. Yeah. First one that I showed, this one?
The one before that.
Just the general one?
Yeah, this one.
This is not true results. This is just a random diagram.
You did that by hand.
Might as well.
Okay, yeah, the wiggling, the certain frequency that seems to be that something is kind of loose.
Yeah, this is show of that. That's just a visual representation.
Okay,
Good catch though, you're right. That's bad.
second question. You assume that movement and forces are the reason for osteoarthritis, right?
I wouldn't say in isolation, but a component of what leads to osteoarthritis, yeah.
Do you have any evidence for that?
Me directly, or
Any?
in this, there's a lot of work has been done this to suggest that the differences in contact area lead to increased forces, which then lead to higher cartilage degeneration, which leads to osteoarthritis.
papers that show that conclusively?
Perhaps not.
I haven't found one.
Okay. And could you suggest what alternative? Would you say it's more cellular?
I don't know,
Okay,
but you know, I was searching for that for quite a while, many years. And we had prospective studies and I don't know what. And never ever was I able, or anybody else that I found in the literature, to prove the connection between more force, higher osteoarthritis.
sure.
So I think I would question whether these orthoses are really there for osteoarthritis or for another reason.
Yeah, and this isn't necessarily the AFOs are not prescribed as a prevention of osteoarthritis. They're prescribed more as like to change the range of motion. And with that is kind of what we're speculating. If these people are at a higher risk of osteoarthritis, can these AFOs change the motion and therefore alleviate some of that force, which may lead to osteoarthritis?
But that's all speculation.
Yes. More or less.
And I don't think it is true.
Okay. Understood. My PhD work will look a little bit more at looking into the actual contact stresses of those joints. So perhaps in 3 years, I can better answer your question.
So send me a copy.
I'll bring you in here sooner than that. Okay, any other questions? Mike?
So all your info seem to just like their stuff during the phase. Obviously don't have it here, but being able to see those people walk, do you think your results, your interpretation would change if you measure sprint phase? You know what I mean?
In terms of whether or not they were successful in doing what they were prescribed for,
Obviously.
perhaps. We did, ideally, what we would have had for this is also motion capture to see that gross motion, to see, like, for a lot of that swing phase, it was to prevent the plantar flexion and foot drop, so to make sure that their toe doesn't drag as they're going through. And ideally, if we could see if their toe was dropping through that motion, we could say yes or no, it did a good job, but I don't know if it would necessarily change, but I think that there's things that are missing. If you're looking at full gait, like we shouldn't just isolate necessarily that stance phase and say yes, no, success. But to include marker motion capture would be good in this sense to see how the hips and the knees and the ankles all move together as they're going through.
And would you say that they kind of learn these walking patterns? Because if you take out some of those graphs instead of all three conditions, take out that one yellow line, you could probably argue that the barefoot condition and the AFO condition are actually pretty similar.
Yep.
And I don't know if it's a case of does it not work or did they just learn this movement pattern?
We've been going back and forth on this as well. So I will also say that when these people are shod, they are wearing shoes that they do not wear without AFOs, which may have confounded our results quite a bit. So we basically have these people come in, we say, bring your AFOs, now walk barefoot, and now walk in a shoe that's a size and a half too big for you. And now put your AFO in, which is what you're comfortable with. So we think that a lot of these people are comfortable walking barefoot and then comfortable walking in their AFO. So the shod condition might not actually mean a lot to us. But one thing that we did kind of see, and I know it's hard to see with all these lines kind of squirreled all over the place, but specifically, if we pick out that bottom purple line, we can see that there's a lot smoother motion in the AFO compared to the barefoot. So perhaps that's a stabilization component, but I don't know if just looking at sagittal plane motion is enough for us to say that it is or is not, and including that subtalar, which is a little bit more rotational, or other planes of motion, might give us a bit more of a full picture, but yeah, I agree. It could be that they've been wearing these AFOs for 18 years and now that's how they walk barefoot, which means, yay, success. Great thing that we gave them an AFO. Now, do they need it for the rest of their life or not? Not sure.
How many trials is this? This is just one.
This is one.
Okay, so I was gonna ask, so when they walk, like those, what, 3, 4 steps across the thing, how much variability do you think they have step to step?
Yeah, quite a bit of variability. We have, so based on our radiation safety guidelines, they're allowed to do a number of trials, and we have them do kind of a warm-up period where we make sure we watch them, make sure that they hit the gate, or sorry, make sure that they hit the field of view, and make sure that they're able to familiarized with the motion before we actually go through with the trial. But even then, there are a couple that we have to do a couple of times over, and this is our picking the best trial. But I agree, there's a lot of variability between them, and there are a couple times where, especially people who have trouble walking, if you instruct them to walk normally, they're like, oh, I don't really think about walking very much, but as soon as you give them that thinking about walking part, it makes it very troubling. For all individuals, we even have healthy controls come in and we say, walk normal, and they're like, oh, I don't really know how I'd walk, and it's been a challenge to try to get them to walk consistently, but we're picking the best one and going with it.
And did you have another question? Okay, so if no one has any last questions for Emily, we will thank her for her talk.